In a previous session, we mentioned that the device associated with complication. We will take some of these complications in the form of case discussion. A 30-year-old lady para 2 vaginal delivery presented with vaginal spotting and gave history of cessation of menstruation for 2 months. She denied any pregnancy as she was on contraception. Question 1. What is the diagnosis according to this slide? Question 2. Complication of it. Question 3. How will you manage her? إذا تلاحظون according to this slide, what is the complication? This is the uterus, and this is the Kappa-T iucd device inside the uterus, and this is a gestational sac also inside the uterus. So the diagnosis, pregnancy with iucd, حمل مع الديفايس. Most of the pregnancies takes place in the iucd intrauterine, but some of them ectopic. ولهذا من الضروري مريضة يصير عندها حمل مع الديفايس exclude ectopic pregnancy. Question 2. Complications. If the device is still inside with the pregnancy, شو راح نتوقع? Complications. Number 1. Miscarriage. It is mainly second trimester miscarriage in 50% of the cases. Infection, septic miscarriage, chorioamnionitis, puerperal sepsis, preterm delivery, low birth weight baby, antepartum hemorrhage, abruptia placentae. But if the device is removed, also there is a risk of miscarriage, but it is 25% as compared with the 50% when it left in situ. Then removal of device will benefit outweigh risk. Question 3. Management of a pregnancy with iucd. According to the RCOG guideline, the device should be removed up to 12 weeks. يعني طول ما المريضة الحمل مالتها أقل من 12 أسبوع يجب رفع الديفايس. زين. If the thread is visible, so it is so easy. We will grasp the thread and try to remove it. But if the thread is not visible in this condition, transvaginal ultrasound to localize its position, whatever it is above the gestational sac or below it. If it is below the gestational sac, in this condition, we told the patient that there is risk of miscarriage with the removal of device, and if the patient accepts, we will remove it. But if the device is above the gestational sac, so removal will be associated with severe damage to the gestation. So the patient will have two options. Number 1, leave the device in situ and continue the pregnancy and removed with delivery as much as the patient had no complication. But once the patient developed complications like infection, fever, septicemia, in this condition, it should be removed. Or if the patient not bear these complications, termination takes place and removal of device. ولهذا المرضى عندها حلين، يا إما تكمل الحمل والديفايس راح يطلع ويا الدليفري، أو نسوي لها termination وبعدين نرفع لها الديفايس. If the iucd is not visualized by ultrasound, plain X-ray should be done. Why? And what is the reasons for which the NHS guideline not recommend removal of the device above 12 weeks? ليش ما يفضلون إنه الديفايس يرفع إذا المريضة كانت حامل أكثر من 12 أسبوع؟ السبب لأنه الجستيشنال ساك راح ياخذ كل اليوتراين كافيتي، فطبيعي الريموفال راح يصير severe destruction to the pregnancy، وأصلا الثريد ما راح يكون واضح لأن يكون صاعد ويا الحمل. So in this condition, the patient will be counseled about the removal of the device by termination of the pregnancy or leave it in situ until continue her pregnancy and with delivery the device is removed, or removal once complication takes place. Missed loop. We will take another case. 32-year-old lady came to the outpatient clinic for routine checking of iucd that inserted 2 months ago. Speculum exam show no iucd thread. ده تلاحظون هنا بهاي الصورة السيرفكس كلش clear but there is no thread. Question 1. What does this condition called? Question 2. Possible causes. Question 3. What is your action? Question 4. How will you measure her? This condition is called a missed loop. A differential diagnosis: 1. The device is expelled. 2. Partial or complete perforation to the uterus. 3. Pregnancy. 4. The string is coiled and hidden within the cervix. يعني بطريقة كلش مبسطة إنه ممكن ماكو أي مشكلة بس الثريد صاير بيه كويلينج وداخل السيرفكس، ولهذا ما دا نشوفه، أو ممكن بس الخيط يكون واقع والديفايس باقي بمكانه. What is the action? First, exclude the pregnancy. تعرفون المريضة مأمنة إنه هي حاطة ديفايس وما تعرف بنفسها إنه الديفايس ما موجود أو صاير بيه مضاعفات، ولهذا يجب استبعاد الحمل. 2. We will use endocervical brush used to prod the cervix. استخدم فد برش ادخلها داخل السيرفكس يعني احركها، احاول اذا موجود الثريد اقدر احصله بهالطريقه. 3. Uterine cavity probed by using forceps. Sometimes a small forceps ادخله through the cervix, try to touch the device. 4. Transvaginal ultrasound to assess whatever the device intrauterine or not. If the device not intrauterine we do plain X-ray. بالإكس-راي راح نلاحظ إذا موجود هذه تسمى الحالة complete perforation وبالحالة لازم نسوي له رفع، وإذا ما شفته بالبلين إكس-راي معناه ولا موجود intrauterine معناته it is expelled، واقع وهي محسة بالديفايس. This slide show a uterine cavity and this is the copper T in situ. This is normal. In another one, in this picture, the device in situ, but in this it is displaced downward. This slide shows us variable site of perforation. إذا نلاحظ هنا ما طول طلع خارج حدود السيروزة يسموه complete perforation, but still it is a partial perforation. This slide shows us الانتيفيرتد البرفوريشن يكون posterior والretroverted البرفوريشن يكون anterior. This plain pelvic X-ray shows us abnormal position of the intrauterine device, and this is complete perforation. Complications of perforation. First of all, bowel perforation, small and large bowel fistula formation, allergy to the copper lead to the inflammatory reaction and adhesion. In addition to that, there will be complication presented to the patient to us with acute abdomen. Management of missed loop. If it expelled, so in this condition, the patient can choose a reliable contraception. ممكن تختار تحط ديفايس مرة ثانية أو ممكن تختار يعني نوع آخر من الcontraception. 2. If it is still intrauterine but there is no thread بمكانه بس ماكو thread. So in this condition, 2 options. First, leave in situ and removed after 8 years of action. تخلص مدة الصلاحية من الرفعة. Or if the patient want to remove it, we can remove. الريموفال حيكون عن طريق الهيستروسكوبي. و if it is not available, dilatation and curettage. البارشال perforation نسوي لها hysteroscopy removal، وإذا complete perforation we should do laparoscopic removal or laparotomy. Why we said laparotomy? Laparotomy indications in case of the patient contraindication to the laparoscopy, or if it is not available, or if there is acute abdomen, or the device is not visualized by laparoscopy, so we should do laparotomy. Or if the patient is pregnant, we treat her like a pregnancy with IUCD as we mentioned previously. This shows us the device, partial perforation, and visualization of device by hysteroscopy, and here removal of device by using hysteroscopy. This is complete perforation, the device between the omentum and bowel, and here laparoscopy removal of the device. And thank you.